the theater itself in one physical environment. So the idea that trauma team goes into the Raptor suite to start the resuscitation intervention all at the same time. So that's where trauma is going. Thank you for the kind introduction. My name is Adrian Wong. I'm one of the anesthetic intensive care consultants from Oxford, and I've been asked to talk to you about trauma ultrasound. And it's quite nice because I think it feeds in quite nicely with the case-based discussion from our Japanese colleagues yesterday evening, and also follows on from what Jacques was saying in terms of the initial resuscitation and where do we go from there. So we are in a small room, so a bit of interaction here. How many of you work in a trauma center? Hands up. That'll be me. How many of you have access to ultrasound machines and use it regularly in your daily practice? The majority, okay. In the trauma setting as well, I presume, then? Yeah? Okay. So what I'm going to say to you is hopefully not too alien. And what I'm going to talk about is, I'll give you an overview about ultrasound in trauma and how we use it in Oxford. We're going to go through some of the FAST and E-FAST principles that Jacques already talked about. And I'm going to then introduce you to the concept of taking it beyond E-FAST. Where does ultrasound in trauma go from there? And hopefully bring it all together and put a way forward for those of you who want to explore the role of ultrasound further. This is where I work. It's beautiful, isn't it? That's Oxford. We're about 50 miles outside of London. We've got a famous university. I show this picture of my hospital because that's the nicest picture of the hospital. That's actually the neuro-intensive care unit. The adult intensive care unit and the trauma setting where I work in is actually in the basement, so you can't actually see where I work. It's also very dark, which lends itself very nicely to ultrasound. Okay. But we are a major trauma center. As Jacques already touched upon, in the UK, we've pooled all our expertise together. So not all hospitals are designed to cope with major trauma centers. So these are it. I am, if you can make it out, number 3, which is there. 4, 5, 6, 7 is London. I'm number 3. So we cover quite a large area. But because it's a fairly rural area, we are a trauma center. We are busy. Most of our traumas tend to be road traffic accidents. We see stabbings. We don't see a lot of shootings or gunshot wounds, except for the fact when hunters, when they go out hunting, shoot themselves accidentally or their friends. We get a couple of those, but generally speaking, we don't get the shootings. The one thing we see a lot of is this, okay? We are a rural area, so there are lots of farms around. A cow can do a lot of damage. The average cow in Oxford, and I Googled it yesterday, weighs about 300 kilograms. And cows panic, like humans panic. So if a dog barks, the herd of cows will stampede. And the poor woman that's caught in the middle will be absolutely smashed. Each cow, 300 kilograms. We see a lot of those. So where do I see the role of ultrasound? Here's a list. And by the way, all my slides will be free, and you can use it, you can share it, and later on, I'll put it on the website, okay? But these are what I think ultrasound is useful for. There's the diagnostic initial resuscitation aspects, the FAST and E-FAST. We use it to put our lines in. Most of these patients are hypotensive. They're very, very difficult to get peripheral access in. You use it to put your art lines, your central lines, et cetera, et cetera. Intubation confirmation of endotracheal tube is fairly new, and I'll touch upon it towards the end. But don't forget that ultrasound has a role for the more subacute and chronic phases of management of these patients. These patients do not get better within the first 4 hours, 6 hours. They are there for the long haul. I use ultrasound in my practice to put nerve blocks in, to help facilitate analgesia, to get them going again, to get them breathing better from the chest injuries they may have sustained. If you're going to put drains in, ultrasound is safer. I don't think there's any discussion about that. More recently, this is a paper from 2015, which they looked when it was a prospective way of looking at the benefits of ultrasound and whether you could prognosticate. And the short answer is you can to a certain extent, but it's not perfect. If a traumatic cardiac arrest patient comes in and you see no pericardial effusion and you see a ventricular standstill, they're dead. You could actually stop there, okay? And I'll give you the reference to it. Now, FAST. This is synonymous with ultrasound and trauma. ATLS has mentioned it, focus assessment by sonography in trauma, been around since the 1996. And I think it's this, the advent of this has led to the fact that diagnostic peritoneal lavage has fallen quite a way out of favor. How many of you do DPL regularly for trauma patients? Never. I've done one. That was about a decade ago. And I think the reason for it is that ultrasound is better. The key principle of ultrasound in the context of trauma is that ultrasound, you're looking for fluid. In the context of trauma, fluid is blood until proven otherwise. We talked about fast and the extended fast. In fast, we do classically 4 areas. The right, left upper quadrant, suprapubic, subcostal. E-fast, there are slight modifications. The modifications are you're looking at the chest to look for pneumothoraces, and you're looking at the supradiaphragmatic area, looking for effusions. Or, in the context of trauma, fluid is blood, a hemothorax. That's what you're looking for. So let's go through a couple of the classical views. So right upper quadrant, okay? Probe, longitudinally aligned. You're looking for your liver as your echo window. The probe is positioned as you can see there. It is a 2-dimensional picture of a 3-dimensional human being. So you're going to need to scan and pan and look around properly. I think that's where people are caught out. They snap what they want to see. They don't spend time actually looking properly. The areas that you need to look for are the hepatorenal recess, the inferior pole of the kidney, and obviously the area below the diaphragm itself. So this is your classic picture that you should see. I've tried to color code that for you. Liver, kidney, bowel, lung. Okay? There, and then there. This is what you shouldn't see, or hopefully would not see. Fluid on ultrasound is black. Fluid in the context of trauma is blood until proven otherwise. So, can I convince everyone? Blackness. Blackness. Okay? The left upper quadrant, this time you're using the spleen as your echo window. Generally speaking, you need to position your probe more posteriorly, so bury your knuckles into the bed. You're looking for the spleen, you're looking for the kidney, you're still looking at the area below the diaphragm. Okay? Again, it's a 3-dimensional structure, so you're going to need to pan your probe to look around things. Spleen, kidney, color-coded. Spleen, kidney. Can I convince all of you that there is blackness there and around it? In my experience, although classically they say you get bleeding in between the spleen and kidney, I think in the majority of times where I found fast positive blood in this area, it's suprasplenic. So just bear that in mind. You need to look above the spleen, below the diaphragm as well. Okay, so suprapubic area, you're looking at the bladder essentially. Your bladder might be filled with fluid, so the important differentiation, if you see the area of blackness, is this fluid within the bladder or outside the bladder? It's a 3-dimensional structure again, so you can orientate your probe in this situation longitudinally and transverse. Some couple of pictures. Bladder, this is a man because you've got a prostate there. And this is a woman because you can see the uterus cervix around the bladder as well. So there, there. In the 90 degree, just tilt your probe. Okay, subcostal. To me, this is probably the most useful shot. However, it's not always possible to get it, but if you can, it probably provides quite a lot of information for you. Those of you who perform echocardiography already will be familiar with this. I tend to use the curvilinear probe rather than the echo probe because of the depth involved in it, okay? And then I don't have to change probe. I just use the same probe and scan all the rest of the abdomen, scan the rest of the lung as well. Okay, This is what you should see. So liver, the 4 chambers of the heart. Color-coded for you. I've got really pretty pictures now. That is what you hopefully shouldn't see. Can I convince you there is fluid around the heart? Yeah? That is a thrombus forming in someone with a road traffic collision. Quite dramatic, isn't it? Without ultrasound, you wouldn't have diagnosed this. It's a dynamic process, and that's why I think it's very useful. EFAS, very quickly. So you're looking for your lungs now. Pleural effusions, pneumothorax. We'll start with effusions first. So essentially, right and left upper quadrant positions, you slide the probe up to look above the diaphragm. Okay? That's it. So this is on the left-hand side. I've annotated the pictures to show you. Kidney, spleen, diaphragm, which is thin slither, and blackness. Blackness is fluid. Fluid is blood in the context of trauma until proven otherwise. If you had to drain it, it's very easy. You can do it under real-time ultrasound guidance. You can see something like that. So fluid is black. You can see the underlying lungs there being compressed. Another picture, fluid is black. It's a dynamic process, and that's why you can see the lung moving in and out into your picture. Pneumothorax. I'm going to spend a bit of time with it because this is probably where a lot of people start using ultrasound with regard to lung and trauma outside of the FAST setting. I tend to use a curvilinear probe. Everyone is different. In the UK, we've got a increasingly obese population, so there are lots of subcutaneous tissues. The linear probe, I don't think, offers you enough depth to get where you need to see. So the curvilinear probe is the one I would recommend. And on a practical basis, the curvilinear probe, if you start using that, you can then scan all the other areas using a single probe. You don't have to keep changing. Where I put the probe, longitudinally, clavicular lines on both sides. How many of you have already done lung ultrasound? Very quickly, hands up. Okay. I think if you're not familiar with lung ultrasound, as a place to start in the context of trauma, this is probably one of the best ones to learn. Okay. What we're looking for is sliding. Pleura, sliding. These are the rib shadows, and that's why I suggest going for the longitudinal approach, because you can use your rib as your markers of where is the linear probe. I put an M mode across the whole thing, and what you're looking for is the seesaw sign. So let's go through that again. Sliding. You can see they call it ants marching. Okay? You drop an M mode over the whole thing, which looks at movement along one plane, and it looks like the seaside. Okay? And I'll show you, but comparing both sides now. So can I convince you on this side that it's moving? They're sliding across that scan. I'm going to play this side now. There is some movement, but that's the chest wall. But can I convince you the pleural line itself isn't moving? So when you drop the M mode across it, you get something like that. And I'm going to freeze both sides for you. Can you see the difference? One is supposed to be, looks like a seashore. The other is supposed to look like barcodes. So the barcodes is bad. And the way I think about it, barcode to my wife is shopping. Shopping is bad. She's not here, so it's fine. Okay, so barcode bad. But there are lots of things that can cause the lung not to move. For example, if you have done an endobronchial intubation and intubated the right main bronchus, your left side won't move. So because of that, you won't see any lung movement. The definitive way of confirming a pneumothorax, and this is where people get caught out, is to actually look for the lung point. And what we mean by the lung point is if you keep your probe where it is, like this position here, as the lung expands, as illustrated by my clever animation, it comes in and out of your picture, okay? In and out of your picture. So when you do your scans, you will see something like this. So if you're a complete pneumothorax, you will see no movement here. If you are over an area of lung which is inflated, so away from the area of pneumothorax, you can still see the marching. If you are at the area where the lung is coming in and out, you will see the lung coming in. Right-hand side of the screen, can I convince all of you that there is that? That is the lung point. That is almost pathognomonic of having a pneumothorax, okay? It's great. To confirm a pneumothorax, it's got very, very high sensitivity, very, very high specificity. So this is why I think lung ultrasound in the context of trauma, if you know how to use it properly, it's very, very useful. We talked about EFAS. JUX talks about a system in place, having a team aligned. This is something I took off ultrasoundvillage.com, which is an EFAS reporting tool. It's free to download, and essentially every single patient, you can have the patient's name when it comes to your door. You do the EFAS, it will take less than 10 minutes, and you've got a reporting there. Okay, it's a nice structure to it, so nothing is missed, hopefully. I'm going to tell you about two more things. I'm going to tell you about where I think lung ultrasound and ultrasound can head. Optic nerve sheath. I don't use, like Jacques, transcranial Doppler very much in the context of the acute setting. I think optic nerve sheath is probably more useful in my hands. How many of you use it already? Okay, it's the minority. It's something new, and it's certainly not established practice by any measure. And what it essentially measures is the diameter of your optic nerve, because in continuation with the dura, the bigger the optic nerve, the increased chance that there might be raised intracranial pressure. Okay, the magic number is about 5 millimeters. It's very, very difficult to. It requires practice. I personally think it's easier to obtain compared to a transcranial Doppler in that setting as well. But that's maybe because of the exposure that I'm with, okay? The other thing I think is very useful in the context of trauma is airway assessment. I was taught, and I still maintain to this day, if you are faced with a trauma patient that requires intubation, prepare for a difficult airway, okay? All the algorithms suggest that you need to prepare for front of neck access, or at least consider front of neck access if all things go wrong. One of the best ways of identifying cricothyroid membrane, ultrasound. When I first started using it, when I use ultrasound for airway assessment, for my percutaneous trachees, when we put it on the intensive care unit, I use it just to look at vasculature. As I got better, I've improved my technique and modified my technique so that I actually look for the landmark I'm actually inserting in. But initially, I just put my probe on it. If there's no big vessels along the way, hopefully I won't kebab it along the way. But since then, I've improved my technique somewhat. Okay, just to put it all together then. Airway, breathing, circulation, disability, exposure, ultrasound has a role for all of them. Okay, and that's why it's useful. Every single step of your initial primary resuscitation, ultrasound can use. You can use an ultrasound machine. So the benefits, rapid bedside, non-invasive, you can repeat it. It can be integrated into your primary, secondary survey. There's no radiation, okay? But, like everything else, you need to be cautious, okay? Operator dependent is probably the biggest problem I see from a day-to-day basis. Hands up, a considerable amount of you have already been exposed to ultrasound. Hands up those who've been gone for a fast course or an ultrasound course. How many of you have been accredited in ultrasound training that you've done? That's a much, much smaller number, isn't it? Okay? And that's my point. I don't want to sound like my primary school teacher, but things need to be done properly. The patients deserve that. When you do your fast scans, are you recording your images? Are you storing your images? Have you got a process in place that allows you to govern, make sure what you're looking at is the right thing? Because mistakes happen. If you haven't thought out the whole process. And it's one to consider. If mistakes are made, it's usually not the fault of the ultrasound machine, okay? You need to know how to use it. People need to know how to use it. A fool with a tool is still a fool. I don't know what the Chinese equivalent is, but it sort of makes sense to me. It is not as sensitive as a CT. So the priority is that CT, okay? In summary, it's not perfect. It does not replace clinical examination. It enhances it. It definitely does not replace the CT. It requires training, and it requires good clinical governance because our patients deserve it. Okay? Like I said, all my slides will be up, and you don't have to take pictures, although it seems very popular. These, again, the list of all the useful pictures, they're all free. So by all means, and ultrasound clips are very quick, so you can look at them between your coffee break and what have you. It's very interesting. So I'm happy to take questions. That's my email. We run a couple of fellowships in Oxford. If you just want to come and see what we do, or come and have a holiday, it's a pretty place, you're more than welcome to drop me a line. Thank you.